Okay, it's on.
Okay. So again, I want to welcome everyone to this Ethio-American Doctors Group sponsored webinar series number 16. Today's presenter is going to be Dr. Zariun, who's familiar for most of you guys. This is part one of two on mechanical ventilation. And Dr. Zariun, the floor is yours.
Okay. Hey, thanks everyone. Sorry for a little delay. I didn't realize the time, but it went in front of me. So anyways, so I'll go to my topic. So I'll be talking about, mechanical ventilation mostly, but I think since mechanical ventilation, it gets difficult when we manage, especially ARDS patients and COVID patients. I have to touch a little bit of that. Then, I'll go into the simpler aspect of the ventilator. Also, we'll try to dive, some of the important details of, this management. So, I think before I go into the mechanical ventilation, I'm going to cover, ARDS and severe COVID pneumonia. So I think probably most of you might know that what ARDS is. ARDS is a disease where, you could have an initial insult in the lung or somewhere else. And the body will have an immune response, but will have an immune response, a very aggressive immune response, and especially attacks our own lung cells. And you will see a diffuse injury in the lungs in a form of edema or whatever. So this process has to be diffuse because the body, doesn't differentiate between which lung cell or which alveoli. So it attacks the whole alveoli. So you will see a diffuse process. So the typical cause for this is, usually pulmonary origin causes, like you will have a pneumonia, or you will have, some kind of, contusion or whatever, aspiration. Then you develop a full diffuse infiltrates, or you could develop, like, for example, after having a pancreatitis or or traumatic brain injury, somebody hit your brain and you develop pulmonary edema, or somewhere you are burned and you develop pulmonary edema. So it is an immune response injury, and it's a diffuse process. So that's a characteristic of ARDS. COVID pneumonia, also the entry of port is upper respiratory, then goes to the lower. So one of the difference between these two you see is COVID pneumonia seems to primarily attack the pulmonary vasculature, the pulmonary endothelium. So there is some microvascular thrombosis there. There is also vascular dysregulation, which means areas of hyperperfused, areas of underperfused. So and then that process on the vascular side, with time can slowly progress to the alveoli and involve the alveoli. Then you start to see this diffuse edema, which looks like ARDS. But in the early phase, you see very few infiltrates, and the main problem is usually in the vascular side. Whereas in ARDS, it's a diffuse process. It involves both the lung cell, the alveolar cell, and the vasculature. So you start seeing infiltrates early on. The vessels start to become leaky, and there will be a lot of fluid leaking out to the alveoli, and the lung gets heavier and heavier, and this whatever edema sits at the dependent portion of the lung, and the lung size gets smaller. What can be filled by the air gets smaller as the fluid takes a lot of portion of it. And in between the fluid and the lung filled areas, there is an area which intermittently opens and closes. I'm talking about the alveoli. So that's what happens in ARDS. So, but in COVID pneumonia, it starts from the vascular process, and and there will be hypoxic due to the vascular origin. And if we don't watch them, these patients, start to work hard, breathe hard, and as they breathe hard, they stretch their alveoli cells really hard, and that slowly starts to cause the injury, and they go into the next phase. Where they are more sicker and more tend to die. So we kind of have to watch them early on, give them antiviral, give them the support they need. So those are just a brief short summary. So going into my slides. So again, the hypoxemia, is it due to typical ARDS? As I said, at the initial phase it is not. At the later phase it looks like ARDS. So going forward, to define, ARDS and so on. What's ARDS? ARDS is an inflammatory disease of the lung, which is characterized by bilateral pulmonary. So it has to be bilateral. Again, the body doesn't differentiate, this lung cell from that, or alveolar tissue from. So it attacks diffusely. And after this, what happens is the pulmonary compliance will be decreased due to the diffuse edema, and hypoxemia happens. Usually it starts from the lung, pulmonary in origin, but there are extrapulmonary causes of it as well. And the patients, when they die, when these ARDS patients finally die, they die of not because of hypoxemia, that we are able to prevent hypoxemia is using the ventilator. They die of multiple organ failure. So how this multiple organ failure comes is one, as I said already, say you have pneumonia, and the pneumonia causes ARDS. So that means there is a very severe inflammatory response, and the pneumonia has its own mortality. When you go to the ARDS phase, you have really higher mortality. And on top of that, if you put them on a ventilator, and this ventilator really not well measured, but excessive pressure and volume, then you add further mortality. So the injury, the immune injury, and the ventilator-induced lung injury, all this accumulated, what would cause is a cytokine storm, and this cytokine storm will cause organ failures, and the patients die of that. So what you should know is that, I think, the hypoxia, you will fix it. But, it is the ventilator-induced lung injury and the ARDS all together causing cytokine storm and, multiple organ failure, and finally kill these patients. So your goal is to prevent that. One of the ways to prevent is, if there is pneumonia, you have to treat them early on. And when it is in the ARDS, you have to give them appropriate support, which is, you want to give the minimal support they need. If you do excessive ventilation, what happens is, the lungs further will be injured, and, the days later will be facilitated. All you did was prevented the acute days from the hypoxemia, but the patients will end up dying later. So, as I said, those are the causes. The treatment for ARDS is only supportive. There is no known effective treatment, and mechanical ventilation is the main support method. This is the Berlin definition. So, as you said, it has to be acute. It has to be acute within 1 week. The chest imaging should show bilateral infiltrates, and the origin of edema or the lung edema should not be explained by fully by the cardiac cause. So you need to have some kind of, it can be both, like, a cardiac and, non-pulmonary, non-cardiac origin, but it shouldn't be explained by that. And the degree of ARDS is defined as mild if the PaO2 over FiO2 ratio is less than 300, and moderate if it is less than 200, and severe it is less than 100. So those are the Berlin definitions. And, these are the causes: direct and indirect. Direct means the pulmonary origin, pneumonia, aspiration, contusion, pulmonary embolism, fat embolism, inhalation injury, and extra pulmonary causes is the commonest is sepsis. Severe trauma can cause, TBI, drug overdose, acute pancreatitis, and so on. So, again, the characteristics of these patients, ARDS patients, they will have pulmonary infiltrate, they have heavy and edematous lung, and their lung is stiff, and they are hypoxemic. How about the specific lung features? Specific lung, ARDS lung is, usually mentioned as a baby lung, which is to say that the volume of the lung, which can be, air-filled, is smaller, much smaller actually. And, if normal person has about, 4 liter, air capacity, ARDS lung probably has, a total of, 1,000 ml, which is including the residual volume. If you see on the picture up top there, the part which is B is the one which is aired, or the baby lung volume, and C is it is the intermediate zone, so partially filled. A is totally wet and cannot be filled, totally collapsed lung. So, and as I said, it has heterogeneous, morphology. The lung is not, when you look at it, it's not uniformly looking the same, but, there are areas of air-filled, there are areas of, partially collapsed and completely collapsed. So there's a heterogeneous morphology. And the lung is stiff. That means in order to open these lungs, there needs to be a very high force or high pressure. That's why the patients always in ARDS look dyspneic. They have to really work hard to open their lungs. And if we put them on a ventilator, the same thing. We have to use a higher pressure to open the lung. This is because the lung is stiff or less compliant. Again, this is the ARDS lung. As you can see, there are different zone and feature there. So how about the outcome? So, still, ARDS is a high mortality disease, between 24 and 60%, depends on the age and the several risk factors the patients may have. So older age tend to die, younger age tend to survive, but it's a huge mortality once the patient has ARDS. And, these patients, after you survive them, they usually may have some kind of residual lung disease. That means, they may get easily dyspneic, or, need oxygenatome or something. So, it's a serious disease. So I think if we can, we should prevent it at all costs, and we should minimize the injury. And some are unable to return to work due to their illness. They will have cognitive deficit, delirious, they will be very weak, they will be depressed, because they will be on a ventilator for several days, sometimes weeks, and months of therapy, and they will have serious morbidity out of this. So it's a serious disease. And the treatment, again, supportive, no treatment, and mechanical ventilation is the main supportive mode. And these are the randomized clinical trials on ARDS, some of them. But, I think, up to in the late 90s, 1990, what most physicians were focused on is correcting gases. So they give higher 12 cc per kg ideal body weight of tidal volume just to correct the gas, because the thought was, gases, the hypoxemia is what's killing them. So, but later on, some of the researchers, questioned this and started to do research. One of the first researchers, Mato et al., as you can see there, and he studies about 50 patients, and they compared between low tidal volume, which is 6 cc per kg, to high, the control being at the time they used about 12 cc per kg. And the difference was, the mortality in the low tidal volume is, much lower than compared to the, the controls, with a huge statistical significance. And then there are many confusing studies, but then finally the larger study, which we call it the landmark study. It's called ARDSNet trial or ARMA trial, which studied roughly around 430 patients in the treatment in arm, control arm. So the treatment arm about 6 cc per kg tidal volume, and the control arm is about 12 cc per kg. So as you can see, there is about 9% absolute risk reduction in mortality. So this was huge, and it was statistically significant. So this sealed the treatment. So from then onwards, it is a standard of care that you need to treat ARDS patients with low tidal volume, and your focus is not correcting the gas. Your focus is preventing the lung injury caused by the ventilator fire. So you try to give them minimal acceptable gas in order to reduce the mortality which can be added by the ventilator. So, this is the one thing for sure we know that, a lower tidal volume, 40 to 6 cc per kg, based on ideal body, it is better than 10 to 12. Most of the other things still, there was a lot of questions, but this is one thing we have to make sure for ARDS patients when it comes. So for other patients, you can, be liberal. Here I'm talking about ARDS patients. So excessive mechanical ventilation can cause, ventilator-induced lung injury. Ventilator lung injury, once it happens, it further progresses the existing ARDS. That means, they are even, rather than supporting or calming the lung, the ARDS will be worse. I mean, the patient is unable to breathe, the patient is hypoxic, the lung says, I can't oxygenate this person, and they fail. So what we did was we let the patient rest on a ventilator, but we did not let the rest. If we can, the best way to heal these ARDS patients is to let them rest and survive. For example, the best treatment, would be, to put them on ECMO and let the lung rest. That's what we do, like the same thing. If the heart is sick, what you do, you let it rest and heal. If the lung is sick, you let it hurt and, heal. If the brain is sick. So, but in this case, I mean, usually we don't have any other means to get, oxygen into the blood. So we have to use the lung, and, there's no way that you can avoid all the injuries related to the mechanical ventilation. There will be some injuries, but your role is to minimize this. So it delays, this really delays lung recovery, multi-organ dysfunction, days, finally. So, and, the types of villi, there are, volume trauma, which comes from excessive volume, where at the end of inspiration, there will be distension over distension, because you think the lung is normal and you are giving a normal, say 500 cc tidal volume, but the space that's available for you is small, which I said earlier, baby lung, and the alveoli will be stretched. When that happens, throughout the day, and and so on for several days, that it will cause an injury. These alveolar cells will start to injure, and whatever the normal lung tissue available for air would be even further injured. The next one is what we call atelect trauma. This is I showed you the middle zone of the lung is where it's partially open, partially collapsed. So if we don't keep this part open during the respiratory cycle, during inspiration and expiration both, but if it is open during the inspiration, then collapse during the expiration, open during the inspiration, collapse during. So when this accumulates throughout the day, what happens is this area also get injured. So that's why we use PEEP to keep this area open at the end of expiration. And all of this will cause what we call biotrauma, or they will cause an inflammatory response or a cytokine storm and cause other organs to fail, and the patients will have multiple organ failure and die of it. So, so your goal is to do lung protective ventilation, which is proven to be improved survival, as I said, about 9% absolute risk reduction. So really causes lung injury, inflammation, again, it's the same thing. So how about COVID-19? There are a variety of clinical presentations of COVID-19. It doesn't always present like ARDS. Most of them, if they have ARDS, it is usually at a later phase. So, they present with a typical ARDS with hypoxemia. Sometimes they, if you see the Berlin definition, sometimes, you feel like they fulfill the criteria because you see a little infiltrates, on both sides, but it is not ARDS. ARDS is a diffuse process which injures the alveoli cells. So that COVID pneumonia it starts from the vascular side. So, variety of presentation, the first one is, usually calm patients, then dyspneic, which we call the type L, and usually they get treated with oxygen, and we need to assess their work of breathing regularly. That means if the patient breathes deeply, they can injure their own lungs by just really breathing hard. For example, if you remember, like after you play, soccer, and you really get dyspneic, your lung hurts, and it's the same thing. When they do work hard, their lung gets injured, inflamed, and this needs to be watched because some of them they may not feel dyspneic. The next one is they present with mild dyspnea, and the treatment option here includes, some oxygen support or pressure support with non-invasive. The third presentation is excessive inspiratory effort with, we see respiratory greater than 13. And, this is injurious, so we need to think of intubation sooner. And the other is, hyperacute presentation. They present really sick looking, feverish and so on. And this also needs to be intubated. So if you think of intubation in ARDS, it's generally recommended that intubating them early. So very non-uniform presentation, most, usually they are, breathing kind of comfortable. They don't tell you they are dyspneic. They have O2 out of 70. We call this silent hypoxemia, and some are very dyspneic. And when you see the pulmonary vasodilator response, some are quite responsive, some not. When you see the PSCO2, some are, hypercapnic, normal. So you will see all kinds of variety of patients. And we have seen all crazy reports of COVID presenting as stroke, COVID presenting as MI, as DK. So it's a hypercoagulable and, cytokine storm disease. So it can come in any lot of fashions. I just had another patient yesterday who came with COVID with PE. And sometimes sudden cardiac arrest due to all kinds of cardiac complication which comes from COVID. So very astonishing variety, and about 70 to 80% present as type L, which is of vascular origin or atypical ARDS. About 20 to 30% will progress to the typical ARDS pattern. Again, different patients from calm patients with oxygen to someone on a ventilator, someone prone to someone being on ECMO on this other side. So you see all kinds of presentation. Again, if you see the CT, variety of, presentation with their CT, the left one here is where you see typical, COVID in the early phase, very few infiltrates. But they are hypoxemic significantly. And here you see a little bit of, bilateral infiltrates at the periphery. And this is the ARDS phase where you see at the right. So again, the X-ray differences, so many different presentation. So again, this difference, could be due to several factors mentioned. It could be due to the how much virus the patient got, the viral load, whenever whoever gave him. So is it heavy load? Is it small load? The host immune response is another thing which defines how the patient will be presenting. The physiologic reserve and comorbidities are important. like older age, they don't have physiological. If you have comorbidity, especially cardiovascular comorbidity, you tend to have severe disease. And the ventilatory responsiveness, whether the patient responds to that or not, and the time elapsed between their onset and their presentation to the hospital. Some patients feel fine, so they stay at home, they come late, but when they come late and when they are dyspneic, that means they are already developed the ARDS phase. So that's another reason, variety of presentation. So what's the pathophysiological mechanism by which, severe COVID pneumonia causes organ failure? So far, some of the knowns are, first one is the virus itself. So, it causes multiple, the virus infects the lung cell, then goes out to the other organs and infect other organs, including CNS, kidneys. And so the virus itself is one of the first mechanism, especially in the early days of the infection. So, antivirals are effective during this phase. The second one is, the high work of breathing. So the high work of breathing causes lung injuries. That's why we need to watch their work of breathing. And if you see them, deeply breathing or fast breathing, then you should support them somehow. And the next one is unregulated immune response. This causes vascular and endothelial injury, which is widely, everywhere in our body. So that's how it causes multiple organ failure and thrombosis. And the last one is DIC or hypercoagulability. So, and we are trying to treat all of this, but the evidence still is behind. But for the virus, we use antivirals. The earlier you use it, the better, before the viral replication goes really overwhelming the body. The high work of breathing, we support them with pressures, either non-invasive or invasive with intubation, and we also give them oxygen, which makes them to work lesser. And for the unregulated immune response, if that is a major mechanism, steroid immune suppressants are some of the treatments we have used. And for the DIC or hypercoagulability, like some of the places they use, for example, if the D-dimer is greater than 10, they use like Lovenox 0.5 per kg BID instead of just a simple 40 daily Lovenox prophylaxis. And if there is any thrombosis, then full anticoagulation is the way to go. So again, severe COVID pneumonia in the early phase, they are usually asymptomatic, and it's the virus. So, and here is what you need to use antiviral. In the later phase, it's immune response. And initially, so when COVID pneumonia happens, all the preparation was that this COVID pneumonia causes ARDS, and we're going to treat this as ARDS. But later we learned that it is not usually, especially in the early phase, it's not like ARDS, and rather COVID pneumonia. If you see the lung edema is very minimal, the lung weight is normal, unlike ARDS. The lung compliance is almost normal, unlike ARDS. The lung volume is almost normal, unlike ARDS. The lung imaging shows only few infiltrates. And the mechanism of hypoxia in COVID pneumonia appears to be VQ mismatching due to the pulmonary vasculature problems, whereas in the ARDS, it's more of a shunt from the collapsed alveoli. So a wide variety of presentation. So, and then, we started to treat differently. So, they call this, the typical ARDS and typical ARDS pattern. So the early phase is called atypical ARDS or type L, whereas the later phase, the typical ARDS is called type H. And the differences are mentioned here. And again, the main difference is that the COVID-19 pneumonia has a normal compliance, whereas the ARDS has low compliance. So COVID-19 is not necessarily equal to ARDS, but definitely COVID-19 can progress to ARDS. So two phenotypes, again, as I said, L and H, about 70 to 80% when they come to us are as L, and about 20 to 30% could be as, H. And the pathophysiology of L, as I said, the vasculature problem, microthrombosis, severe inflammation, And the difference, again, to repeat here, type L, low elastance or high compliance, low ventilation, low VQ mismatch, low lung weight, whereas the type H has high elastance, high right to left shunt, high lung weight, high recruitability. If you see these two lungs, the type L lung and the type H lung, both of them have similar PF ratio. Both of them have severe hypoxemia. Their PF ratio is 84 and 95, as you see in the top. But you can see how different they are, when you see them on the CT scan. So this is from a real patient. So, and you may say, looking at this, every criteria may look like fulfilled on this, the type L lung here, but this is not ARDS. This is ARDS type. So again, there are differences here. If you see, for example, when they measure the lung between these two patients, of the same degree of hypoxemia, lung weight is 1 gram here. The lung is not heavy. It's almost normal, whereas the lung weight is about 3 kilogram here. And the non-aerated portion is very minimal, about 7%, whereas it is 54% here. The total gas volume is almost normal, about 4 liters, whereas it is very reduced to about 1360 ml. The driving pressure is less than 15. The driving pressure is greater than 40. The static compliance is greater than. So some of the studies based on CT scan. And this is the aerated portion is more the type L one. As for type L, so oxygen treatment is the main treatment. And even if they need intubation, ultimately you use lower pressures on them. Whereas in the type H, pressure is the main treatment. Oxygen is usually not sufficient because these patients are dyspneic and they need to be supported by either invasive or non-invasive pressures. And usually once they are on the ventilator, we tend to use a higher PEEP and a higher pressure in order to open their lung. So they have a baby lung, and low tidal volume is the key for treatment. So how to differentiate between the two? You can look at the CT scan, or you can assess how the lung is, after you give some pressures, and how the lung behaves, as compliant or non-compliant, difficult to open or not difficult to open. So, again, on the bedside, you can assess the respiratory system compliant. The formula is there: tidal volume over plateau pressure minus peak pressure. Or we can assess the recruitability, which means, as we open use more pressure, if the lung has a part which is opened or recruitable, then that's a sign that it is a type H. So we say a lung is recruitable if the following happens: as you increase the pressure or the volume, if the driving pressure decreases, or if the compliance improves, or if the PF ratio significantly improves, that's a lung which is recruitable. Okay, so that can help you differentiate between the two. And again, I mentioned it, they can transition from type L to H unless you watch them and support them carefully. So here, again, the course to see some of them, most of them improve. Some would go to the next phase, the type H phase, and and especially here, the PCL is patient-induced self-inflicted lung injury. So when they work that hard for a long time, they will injure their own lungs. So we have to stop them. We have to support them. And different kinds of disease course. There is a hyperacute where they present really, really sick at the initial phase, and the indolent phases, like they start, some are partially sick and then they slowly improve. And the other one is, it starts slow, but it goes to more sicker patients. So, and sudden or quick deterioration in days is common. Many people die at home because they don't feel dyspneic, and the same can happen in a hospital unless you are careful. These patients, have sudden cardiac arrest of just like that, and so you have to write them, carefully. So supportive treatment is the way to go. So if it is type L, oxygen support is a main treatment. And if you use pressure, you have to use a minimal pressure. Other treatments we can try, position treatment like, proning, pulmonary vasodilators, trying to increase cardiac output. All those means can help. Supportive treatment for the type H, or the typical ARDS one, is oxygen is not alone, is not sufficient, so we use pressure or mechanical assistant. They may need to be sedated, paralyzed, and other kinds of support like proning and so on may be necessary. So again, I'm coming to the ventilator part. So managing COVID-19 pneumonia with patients with hypoxemia. So as you know, I said this oxygen delivery is our profession, and oxygen deliveries is oxygen content times by cardiac output. And so oxygen content is dependent on the O2 sat and the hemoglobin. The PaCO2 is very minimal portion. So we have to, if you want to improve oxygen delivery in someone, the tools we have is the cardiac output, the O2 sats, and the hemoglobin. So, and mechanical ventilation affects both the oxygen content and cardiac output. So it can affect positively, it can affect negatively. So our goal is so that it doesn't affect negatively. So we have to watch out the hemodynamics and also the lung injury and so on. So in oxygen delivery is our business again, and we have to aim for the lowest acceptable oxygen content, which can be O2 sat of 88 to 94, PO2 of 55 to 80, and we allow permissive hypercapnia. That means the PaCO2 can go really high up, and we don't increase the tidal volume or respiratory just to fix that, because our goal is to prevent lung injury. And we have to optimize the cardiac output. We don't want to cause right ventricular failure, especially by excessive intrathoracic pressure. And sometimes transfusion and so on could have a role, but these days are not really that well recommended. So when you think of the oxygenation failure therapies, the first is you increase oxygen. So I have 5 minutes. The first is we'll increase oxygen supply. The second one is we reduce the VQ mismatch. The third one is we decrease oxygen demand. And the fourth one is increase oxygen delivery. So when someone has an oxygen failure, these are our therapies we use. So what can we use with oxygen supply? Our tools are FiO2, increasing FiO2, which can be nasal cannula, face mask system, high flow system, or the pressure system is, either non-invasive, invasive, positive pressure. So after, on a ventilator, after you finish the FiO2, after you finish using the pressure is maximal, then the next thing you can try to use is the inspiratory time. You can prolong that, and you call this inverse ventilation, because normally the expiratory time is longer than the inspiratory. By prolonging this, we use that. So these are the tools we have on a ventilator or non-ventilator system. How about reducing VQ mismatch? So in order to do this, we can treat the underlying disease. We have to keep negative fluid balance. So don't keep fluids going on like, continuous IV fluid and so on. I think the goal is dry lung strategy. So I think we have to keep them as dry as possible. And prompt positioning is known to be helpful. Pulmonary vasodilator, all this will improve VQ matching. So that's that helps the oxygenation. The other is decreasing oxygen demand. Sedation is one, paralysis. By decreasing oxygen demand of the muscles, the oxygen can be directed to the vital organs. Like, by paralyzing, letting the patient muscle rest, the demand from the muscle will stop, and the oxygen can go to the vital organs. That's what we do. And when the same way, when we put them on a mechanical ventilation, by letting their respiratory muscles rest, we are decreasing their oxygen demand. So if they continue to work hard while still on a ventilator, it doesn't make sense. So our goal is to rest them. And the last category, increasing oxygen delivery. How we do it, transfusion is one. Cardiac output augmentation. Typically here we use things like dobutamine, and I think in Ethiopia setting, some dopamine or whatever. So I think, if you have a way of measuring cardiac output, say pulmonary artery catheter or anything, anyways, echo and so on, then augmentation can help. And the last is, ECMO. ECMO also can increase oxygen delivery. I know this is not available in Ethiopia. So, and I think, coming to the real safe mechanical ventilation. So I think we're gonna go deeper just to start just the very few basics. What's a ventilator? Ventilator is, it is simple. I mean, I think from the simple to the complex, ventilator means it is a blower plus a timer. So as you can see here, there is a pressured gas in this cylinder, and there is a hand which is pinching here. So this pinching hand can control the rate that balloon filled or the amount, and it can stop. So that is your timer. So basically the concepts are this. So it's just a variation of ventilators are a variations of blower and timer. So air blower, as you can see here, this will control how much it goes in. During exhalation, there is another timer which controls how much will be exhaled, and it doesn't let it to collapse all the way. When a certain pressure number is reached, which we said, then the valve will be closed or partially closed. So, and as you can see, this is on the, on the hand model here. This is on the real ventilator. There are valves which opens during the inspiration, and during inspiration, the expiratory valve will be closed, and during expiration, the reverse happens. And so the timer does that. So again, the similarities between the lung model and the balloon model here is the same principle. So the classic mechanism, again, during inspiration, the inspiratory valve opened, the expiratory closed. During expiration, the inspiratory valve closed and the expiratory valve opens, and that the lung or the balloon deflates. And how do the ventilators generate PEEP? So what they did was, once a certain amount of air is exhaled, the expiratory valve will be partially closed, and the inspiratory valve will be partially, open. Both of them are partially open. So they, there are pressure sensors here, and they keep whatever the PEEP you said, they assure that PEEP is maintained. There will be resistance so that all the air won't come out, and there will be, also some inflow to keep the PEEP maintained. So this will go on, for the set amount of expiratory time you set on the ventilator. So, and again, ventilator is not just one thing. It's, the total. We have to think of as a, ventilator system concept. Which is there is a circuit. There should be an air and oxygen supply, and the ventilator, by mixing these two, will give you the exact FiO2 and the AC power and so on. So I think I would stop here and see if there is any question. So this is an iron lung in the 1930s when there is polio epidemic. This is how they ventilated. Like the same as the diaphragm causes negative pressure, and that's how it expands. Here you can see they use external negative pressure to open their lungs. So that was actually one of the first ventilators is a negative pressure ventilator, and then later comes to the positive one, which we push air into the lung. And whereas the other one, the prior one, is where we try to suck into the lung or negative pressure. And different kinds of mechanical ventilation, it could be intermittent positive, intermittent negative, or high flow. So I'll stop here and see if there is any question. Thanks.
Thank you, Dr. Zergun. That was an excellent presentation. And this is the first part of part 202 presentation on mechanical ventilation. And on the next presentation on Wednesday is going to go in detail on mechanical ventilation. Today's topic was, in summary, it's mainly the difference and similarity of ARDS and COVID-19 pneumonia. This is the up-to-date presentation. And again, thank you for the wonderful presentation. So before I go to some of the questions, I've seen Dr. Wendosen and Dr. Tola. I don't know that they still on. So if you are Dr. Wendosen, if you have any comment or update, that would be wonderful.
Actually, yeah, it was an excellent presentation. I don't have any comment, but a question to ask. Dr. Zareen, what do you think is the optimal mode of respiratory support for patients who are hypoxemic, but who don't actually need mechanical ventilation? I am referring to COVID-19 patients. The optimal treatment before mechanical ventilation, providing oxygen and correcting the hypoxemic state. Did you get my question?
Yeah, I think, yeah. So I think, before you end up on a ventilator, obviously we have to give, oxygen. I think they work hard in order to get oxygen into their body, not because they have a high, PaCO2. Normally, our body, the ventilation drive is, when the PaCO2 goes up, we start breathing and panting. Like after exercise, there is a lot of PaCO2, build up, and that's how you start. But in this case, usually the PaCO2 is normal. Their problem is oxygenation. And when that is low and they start to breathe hard. So we start with simple nasal cannula, and I think we go to the next one is the face mask kind of treatment. So what we are trying to do is, when you use nasal cannula, what happens is that there will be a lot of mixing from the surrounding air, so the FiO2 will be lower. The reason we use face mask is so that we tend to reduce this mixing, and we try to get most of the air coming from that face mask area, or more from the oxygen. Then the next level is sometimes we use a tight sealed mask. Or something which has got a reservoir, like a non-rebiter. So, if you see, on Dr. Mola's presentation the other day, he presented some bag, behind, the oxygen outlet, which contains oxygen. And, when the patient tries to suck, most of the air comes from that one, and, that kept being filled. So these are the ways where you can continue to support them. The other one is, is what we call a high flow system, or OptiFlow. So this is basically like it can give you about 60 liters, up to 60 liters of oxygen supply through your nasal pillow, and it will satisfy your need. There are people, for example, who tried, a high flow system, and they are able to hold on their breath for like minutes, because this, normally when we breathe at a rate of about 30 liter, or so, but this is 60 liter. When we are sick, we breathe even much faster. So for a normal person, this can satisfy even your ventilatory needs. So it's a very high flow system. So as long as it's kind of well sealed in the nose, we have to make sure that the patient try to close their mouth and they get most of their support from there. That's another way we can support them. So if all this fails, we go to the mask and a little bit of pressure. So I think these are all the things you have, going, if I answer. The other thing we have to do is, I think proning is important during even this phase. In a position treatment, awake proning is really good. And, I think they have to be rest. Some people, they are so bored, you see them walking around and so on. That increases their oxygen demand. So I think resting is part of the treatment. And, if they are anxious or something, you have to give them time. So I think you have to think of all those principles: decrease oxygen, supply, oxygen demand, cardiac output and VQ mismatching. So you are trying everything. Giving them oxygen, you are telling them somehow to rest. You are VQ mismatching by asking them, to prone and so on. And, if there is a way to increase the cardiac output, you use all the means. So you think of all the categories, in each phase.
Okay. So some of the other questions are, before I go to the questions, I know a lot of you guys are asking to share the slides, which we will, as usual. So we'll share the slides. And some of you guys have shared your email. We'll add your email to that as well. And so the other question, there are a lot of questions on the treatment of COVID. So one of the questions, Dr. Zariun, is what are the antivirals we use, as well as can you comment on hydroxychloroquine and chloroquine used for COVID?
Well, I think, the antivirus, this is still on progress. I think probably Elias will be more suited for this, as he's infectious disease physician. Now we are seeing more and more data that remdesivir may work on this. And there are, some, antiretroviral medication which are also being treated. The hydrochloroquine question is still, lingering there. There are some people who stop using hydroxychloroquine. Many still are using it, because there isn't much options to treat it. So I think, those are the few ones. And I think if I say something is, if you use it in the earlier phase. That's when the viral replication and spreading happens. And, the same thing, like in the flu season, if you use the flu medication, you better use it early, before the viral replication. So it's the same principle here. Elias, I don't know if you have anything to add.
No, that's true. The only thing to add is there's nothing approved by FDA. And as Dr. Zariun just mentioned, remdesivir just got emergency authorization to use. So everything is on a trial level, and our experience with hydroxychloroquine in ICU patient is unfortunately not great. So so it's getting out of favor for ICU patients, and like he said, the IL-6 receptor blockers have a better outcome. Again, data-wise, there are very limited data. So most of the thing we do is based on experience. Having said that, there are more questions especially on sedation. So what do you use sedation and pain medication for? Mechanical ventilation is the first question for Dr. Zariun.
So sedation, I think you can use whatever available tool you have. Here it's advanced world, so we have many options. So I think if you guys have propofol, I would say that's a good one. I think I know propofol is a available cheap medication. So that will be a good one to use. And, the others, whatever you have, morphine, fentanyl, or diazepam, any of those things, could work for you. But I think one thing I would like to say is if you use sedation, there are good ways and dangerous ways of using sedation. The dangerous way is like we think we sedate way too much, and these patients when we sedate them so much and for so many days, we are making them non-human. That means humans are not designed to be sleeping all this time. So when they wake up, you will mess up their brain, and your goal is for them to get treated of this and get better and function out there. So one of the things we for sure know is heavy sedation affected these patients really bad, and they can't go back to work. You'll have them survive, and they have really bad brain injury. So I think the minimal sedation is the better. That means you have to use a goal. We have for example, in the US, we use what we call RASCAL, which means Rapid Agitation Scale. Agitation and sedation scale, there are goals you achieve. Usually we use 0 to 2. That means either if they are calm, 0 means awake and calm. The ventilator, the patient is calm on the ventilator, then you may not need to use a drip, maybe PRN here and there, but you let them, you are worried, if you are worried about, them self-extubate, then you restrain them. But most of the time you leave them alone. If they are anxious or uncomfortable looking and so on, you can target something like where if you call their name, they can wake up. So, but you don't want a really heavy sedation unless the patient is severely hypoxemic and you really want to take down all their, demands away.
Okay, so some of them ask about the mechanism of the antivirals. Just remember this, the new one is it's anti-RNA synthesis inhibitors. That's the only direct antiviral right now for this virus directly. So, and the other question for you here is about proning ventilator patients. And you can add that too, and you can comment also on the convalescent plasma antibody treatment. Those are the two questions for you, Dr. Zario.
Is it about proning, you said?
Yeah, so the question is, is it possible to do proning on mechanical ventilation, not responsive to other recruitment treatment? And what's your comment on convalescent plasma treatment?
Well, I think, it's definitely worth trying, especially if you have a young patient and so on. I think if the system can prepare this thing for you, I think it's worth trying. But, again, it's a hit and miss. There are people who responded for us very well, and there are people who did not respond very well. So I think, it's worth trying, especially if you have a young patient. I think it's worth trying, Elias, I don't know if you wanted to comment on that. But on the other hand, on the proning side, I think, proning definitely works, in these patients, in most of these patients. But the big concern I have is when you prone, you really need to have your staff trained and prepared. Otherwise, this may be injurious, disastrous. What we have seen in the US is those hospitals who try to prone without getting the staff ready. They try to prone, the process is not thought out, so there will be a little disconnection from the ventilator or some line out or something, then the patient coughs. That's what happens. So everybody learned it really the hard way, especially in Ethiopian setting. That will happen unless you are careful. I think you need to have a protocol written out. You need to have a training and preparation, because these are really sick patients playing at the age of life and days. A little thing will be enough for them to die. So you have to have a staff ready for this thing.
Okay, thank you. I think our time is up, as you can see. So before we go, I want to mention a couple of things. Next Wednesday, reminder part 2, and Friday we have question and answer session, as well as we'll have some cases to discuss with you guys on mechanical ventilation, and hope to see you guys on Wednesday. Unless there is any more item, I think that will end our topic today. And thanks for presentation, Dr. Zariun, and thank you everybody. Bye bye. See you next time.
Thank you.